Welcome to Med Studious, your go-to channel for high-yield medical education. Today, we are diving deep into the Advanced Pulmonary Toolkit, a comprehensive clinical dashboard that integrates 3 essential diagnostic pillars: functional testing, biochemical biomarkers, and anatomical imaging. Whether you are preparing for USMLE Step 1, Step 2, your MBBS finals, or nursing board examinations, mastering pulmonary diagnostics is non-negotiable. Modern respiratory medicine is no longer about a single test. It is about triangulating multiple data streams to arrive at the correct diagnosis and management plan. In this video, we will walk through cardiopulmonary exercise testing, the Methacholine challenge, Procalcitonin, C-reactive protein, and the full hemoptysis management algorithm, from bedside to bronchoscopy. Stay with us, because by the end of this video, you will think about pulmonary patients in a completely different way. Let us begin. Before ordering any pulmonary function test, the first question a clinician must answer is this: am I trying to measure what the lung can do, or am I trying to provoke what the lung will do under stress? These 2 questions correspond to 2 entirely different tests. For unexplained dyspnea, where you need to determine whether the limitation is cardiac, pulmonary, or muscular, the correct tool is cardiopulmonary exercise testing, or CPET. It answers the question of capacity. On the other hand, if your patient presents with atypical wheeze or suspected asthma, but has a normal baseline spirometry, you need a provocation test, the Methacholine challenge test, or MCT. MCT asks, is there hidden airway hyperresponsiveness lurking beneath a normal resting FEV1? Key indications for CPET include dyspnea differentiation, heart failure transplant evaluation, and preoperative risk assessment for lung cancer or lung volume reduction surgery. MCT is your go-to for diagnosing asthma when traditional testing is non-diagnostic, and for occupational asthma screening. Choose wisely. Wrong test, wrong answer. Cardiopulmonary exercise testing is the most physiologically comprehensive non-invasive test available in clinical medicine. It simultaneously interrogates 3 organ systems at once: pulmonary, cardiovascular, and skeletal muscle. From the pulmonary domain, CPET captures minute ventilation, tidal volume, and respiratory frequency, parameters that reveal ventilatory inefficiency or mechanical obstruction during exertion. From the cardiovascular side, it monitors heart rate, blood pressure, oxygen pulse, and a continuous EKG, detecting chronotropic incompetence, ischemia, or arrhythmias provoked only by exercise. Skeletal muscle metabolism is assessed through lactate and external workload measurements. Critically, at the intersection of all 3 systems sits VO2, oxygen uptake, the single most powerful variable in the test. And here is the high-yield exam pearl. Peak VO2 outperforms every other clinical data point, including ejection fraction and BNP, in predicting mortality risk in patients with severe heart failure. A peak VO2 below 14 milliliters per kilogram per minute is a threshold used to list patients for cardiac transplantation. Remember that number. Now let us understand the precise pharmacology and interpretation of the Methacholine challenge test. Methacholine is a synthetic cholinergic agonist that directly stimulates muscarinic M3 receptors on airway smooth muscle, causing bronchoconstriction in a dose-dependent manner. The test is delivered via nebulization in incrementally increasing concentrations, from as low as 0.016 milligrams per milliliter all the way up to 16 milligrams per milliliter. After each dose, FEV1 is measured. The test is considered positive and clinically significant for airway hyperresponsiveness when FEV1 drops by 20% or more from baseline. The key thresholds to memorize are a provocative concentration causing a 20% FEV1 drop, known as PC20, at or below 8 milligrams per milliliter, and a provocative dose, PD20, at or below 200 micrograms. An important clinical caveat: false positives can occur in COPD, congestive heart failure, allergic rhinitis, and cystic fibrosis, so always interpret MCT results within the full clinical context and never in isolation.
Before performing a methacholine challenge test, strict medication washout protocols must be followed to prevent false negative results, where a bronchospastic airway is pharmacologically masked, making the test look falsely normal. Here is the washout timeline you must memorize. Inhaled corticosteroids and leukotriene modifiers must be stopped 4 weeks before the test, but only if the clinical question is whether the patient requires these anti-inflammatory medications at all. Long-acting beta agonists, or LABAs, require a 36 to 48-hour washout. Theophylline, a methylxanthine bronchodilator, must be cleared for 24 hours. Short-acting muscarinic antagonists like ipratropium and oral albuterol require 12 hours. Finally, short-acting beta agonists, albuterol and levoalbuterol, need only 6 hours. Regarding absolute contraindications, never perform MCT if FEV1 is below 50% predicted, or below 1 liter, if the patient has had a myocardial infarction or stroke within the past 3 months, if hypertension is uncontrolled, or if there is a known aortic aneurysm. These contraindications exist because induced bronchoconstriction in these settings can be life-threatening.
Now we shift from functional to biochemical diagnostics, specifically the kinetic behavior of procalcitonin and C-reactive protein following a bacterial insult. Understanding the temporal dynamics of these two biomarkers is essential for exam success and clinical decision-making. When bacteria trigger systemic infection, procalcitonin, or PCT, spikes sharply within 6 hours, driven by cytokine-mediated upregulation of the calc1 gene in virtually all parenchymal cells throughout the body. PCT peaks at approximately 18 to 24 hours. Meanwhile, CRP is rising slowly during this same period because it is synthesized exclusively by hepatocytes in response to interleukin-6, a later-phase cytokine signal. CRP peaks at around 48 hours. Here is the critical clinical insight. PCT's rapid rise and short 24-hour half-life make it the superior tool for antibiotic de-escalation, a principle validated in the landmark ADAPT sepsis trial. CRP's slower, more sustained elevation makes it the preferred early-phase sensitivity tool for initial triage. Think of PCT as the speedboat and CRP as the tanker, both useful, but at different moments in the infection timeline.
Let us now compare procalcitonin and C-reactive protein across 5 critical clinical dimensions. First, biological source. PCT is produced by parenchymal cells globally, thyroid C cells, lung, liver, kidney, in response to bacterial endotoxins. CRP is synthesized exclusively by hepatocytes, triggered by interleukin-6 during the acute phase response. Second, specificity. PCT carries high specificity for bacterial infection. It does not significantly rise in viral illness, making it a valuable stewardship tool. CRP, in contrast, is highly nonspecific. It rises in any inflammatory state, including malignancy, autoimmune disease, surgery, and trauma. Third, optimal clinical use. PCT is the preferred biomarker for guiding antibiotic de-escalation and stopping therapy in ICU and severe community-acquired pneumonia. CRP excels at initial diagnostic triage and daily monitoring of inflammatory trajectory. Fourth, key limitations. PCT can be falsely elevated in massive non-infectious stress, chronic kidney disease, and medullary thyroid carcinoma, a classic exam trap. CRP is hampered by its nonspecificity and the fact that baseline values vary significantly across populations. Fifth, and critically for resource-limited settings, CRP costs 5 to 8 times less than PCT and is universally available.
This slide presents one of the most clinically powerful and exam-relevant algorithms in modern pulmonology, the PCT-driven antibiotic de-escalation protocol for lower respiratory tract infections. A crucial caveat first, PCT should never be used in isolation to initiate antibiotics. Clinical judgment always takes precedence. Now, the 4-tier decision framework. If PCT is below 0.1 micrograms per liter or has dropped by more than 90% from peak, bacterial infection is highly unlikely, and antibiotics should be stopped. If PCT falls between 0.1 and 0.24 micrograms per liter, or has dropped by more than 80%,
bacterial infection remains unlikely, and stopping antibiotics is strongly encouraged. If PCT is between 0.25 and 0.5 micrograms per liter, bacterial infection is possible. Do not stop antibiotics yet. Reassess the next day. If PCT exceeds 0.5 micrograms per liter, bacterial infection is highly likely. Definitely do not stop antibiotics. And if the patient is hemodynamically unstable, actively consider broadening antimicrobial coverage. This protocol has been shown in multiple randomized controlled trials to reduce antibiotic exposure by 25 to 40% without increasing mortality.
We now pivot to anatomical diagnostics, beginning with the vascular anatomy that underlies hemoptysis, one of the most high-stakes presentations in respiratory medicine. The lung receives a dual blood supply, and understanding which vessel is bleeding determines both prognosis and intervention strategy. The pulmonary arteries carry deoxygenated blood from the right heart to the alveoli for gas exchange. They operate at low pressure, roughly 25 over 10 millimeters of mercury, and account for only 5% of massive hemoptysis events. When they do bleed, it is usually through necrosis, pseudoaneurysm formation, the classic Rasmussen aneurysm and tuberculosis cavities, or pulmonary arteriovenous malformations. The bronchial arteries, in stark contrast, originate directly from the aorta and operate at full systemic arterial pressure. Chronic inflammation from tuberculosis, bronchiectasis, or lung tumors triggers pathological angiogenesis, recruiting new bronchial vessels that are hypertrophic, tortuous, and structurally fragile. These vessels rupture under systemic pressure and account for 90% of massive hemoptysis cases. This is why treating the bronchial circulation is the cornerstone of hemoptysis management.
Massive hemoptysis is defined as greater than 200 to 600 milliliters of blood expectorated within 24 hours, and it carries a mortality rate approaching 80% if untreated. The critical physiological insight is this. In massive hemoptysis, patients die from asphyxia. The airways flood with blood before exsanguination can empty the vessels. Management follows a rapid 3-step sequence. Step 1, positioning. Immediately place the patient in the lateral decubitus position with the bleeding side down. This uses gravity to contain hemorrhage within the affected lung and protects the contralateral, unaffected lung from blood aspiration. Step 2, secure the airway. Consider early intubation based on respiratory status. Use an endotracheal tube larger than 8 millimeters in internal diameter to allow passage of a therapeutic bronchoscope. If the bleeding side is known, selectively intubate the contralateral main stem bronchus to isolate and protect the healthy lung. Use smaller tidal volumes, 3 to 4 milliliters per kilogram, to minimize barotrauma. Step 3, stabilize and reverse coagulopathy. Administer tranexamic acid, either nebulized or intravenously, to inhibit fibrinolysis. Immediately reverse any underlying coagulopathy. Vitamin K or prothrombin complex concentrate for warfarin toxicity, and DDAVP for uremia-associated platelet dysfunction.
Once the patient is stabilized, the diagnostic workup follows a structured 3-tool pathway. The first tool is the chest X-ray, the mandatory first-line baseline investigation. It can localize the bleeding site in 45 to 65% of cases and identify a causative etiology in 25 to 35%. However, an important caveat, chest X-ray misses up to 10% of pulmonary malignancies, so a normal CXR never rules out lung cancer. The second and most important diagnostic tool is multi-detector CT angiography, MDCTA. This is the pre-intervention gold standard and must always be performed with intravenous contrast enhancement to visualize the vascular anatomy. MDCTA localizes the bleeding site in 70 to 88% of cases, identifies the etiology in 86%, and critically maps both orthotopic and ectopic bronchial artery origins prior to embolization, essential for procedural planning and spinal cord protection. The third tool is flexible bronchoscopy, which serves as a bedside therapeutic and localization tool. It allows direct airway clearance of blood clots, cold saline lavage, epinephrine instillation for vasoconstriction, and balloon tamponade for temporary hemorrhage control. Its diagnostic yield for etiology, however, is significantly lower, only 2.5 to 8% compared to MDCTA.
Bronchial artery embolization, BAE, is the definitive interventional treatment for massive hemoptysis and the current gold standard, excluding cases caused by trauma or iatrogenic vascular rupture, which requires surgical repair. The procedure works by introducing embolic material, typically polyvinyl alcohol particles or coils, into the hypertrophic bronchial arteries, blocking blood flow and collapsing systemic pressure in these fragile vessels. BAE achieves immediate hemostasis in 82 to 100% of cases, a remarkably high success rate for a non-surgical intervention. However, there is one critical anatomical danger that every exam candidate must know: the artery of Adamkiewicz. This vessel, also called the arteria radicularis magna, is the dominant arterial supply to the anterior spinal cord, and typically originates from a left intercostal or subcostal artery between thoracic vertebrae T9 and T12. In some patients, the artery of Adamkiewicz shares its origin with a bronchial artery. Inadvertent embolization of this vessel carries a 1.4 to 6.5% risk of anterior spinal cord ischemia and permanent paraplegia. This is precisely why pre-procedure MDCTA mapping is not optional. It is mandatory. We close with the most important concept of this entire video: the synthesis. Modern pulmonary diagnostics is not about a single test. It is about triangulating three complementary information streams to achieve definitive management of the undifferentiated pulmonary patient. The first stream, the how, is functional and physiological. Tools here are CPET and the Methacholine challenge test. They measure dynamic impairment, unmask hidden hyperresponsiveness, and define systemic capacity limits. The second stream, the who, is biochemical and infectious. PCT and CRP answer the question of which inflammatory agent is responsible and guide the stewardship decision of when to start and, more critically, when to safely stop antibiotics. The third stream, the where and what, is anatomical and vascular. MDCTA and flexible bronchoscopy map structural failure, localize bleeding sources, and guide life-saving endovascular or bronchoscopic intervention. When these three streams are integrated, the clinician transforms from a pattern recognizer into a systems thinker. That is the standard modern pulmonary medicine demands. Thank you for watching MedStudious. Please like, comment, share, and subscribe to MedStudious.